Shall I start?
Can start, yes.
Okay. So good evening, everyone. So today I'll be doing a case presentation on keratoconus. Myself, Dr. Annu Teres Taliyat, Primary DNB, Shankar Eye Hospital, Bangalore. And for this session, we have two moderators, Dr. Mallikarjun from Shankara Shimoga and Dr. Akansha Sinha from Shankara Kanpur. So we'll move on with the case presentation. So our patient was a 26-year-old female. She was a student from a resident of Hannur, Karnataka, and she came to us with chief complaints of diminution of vision of the left eye more than the right eye since the last 2 years. She also had a complaint of watering on and off for the last 2 years. History of presenting complaints. The patient gives a history of gradual, progressive, painless diminution of vision, which was more in the left eye than the right eye, which worsened over the last 2 years. It was associated with on and off watering, and patient also gives a history of excessive eye rubbing. The patient was prescribed glasses earlier, but she was not using it. There is also a history of consulting a medical college 1 year back with an ocular procedure being done for the right eye as recalled by the patient, which involved putting drops and exposing the eye to light. And also she was advised for a corneal transplant for the left eye. There was no history of pain, redness or photophobia. No history of flashes of light or floaters. And there is no history of contact lens wear. Coming to the past
Once again,
history.
please go back to the previous slide.
Yes, ma'am.
So you presented it well. So whenever you are presenting your chief complaint about diminution of vision, first thing it should come like DOV for distance or near or both. So just add that also, diminution of vision for distance and near or only distance or only near, and rest of the things as you said, like gradual in onset, progressive, painless. Other thing you can elaborate on, like you have written, patient was prescribed glasses but was not using it. So you could like ask her why was she not using it? Was she not comfortable with the glasses, the vision which she was gaining with the glasses, or there was frequent change in glasses that could have been added in this?
Yes,
Apart
ma'am.
from that, you could ask like any worsening of symptoms of blurring of vision. Was it worse during nighttime, or there were associated glare or halos during nighttime that
Yes, ma'am.
could be added in this history?
Yes, ma'am.
And the procedure which she underwent in that medical college. So, like post that procedure, did she feel any improvement in vision, or there was worsening of vision? So that also could be added. Like post procedure, what did she feel?
Yes, ma'am.
Okay.
So coming to the past history, there was history of severe itching present and with waxing and waning of the symptoms. And she gives a history of using over-the-counter medications for the same. But currently, there is no history of using any eye drops or medications. Coming to the systemic history, she's an asthmatic with a history of use of inhalers on and off, and no history of other systemic illness or regular medications. There is no history of similar complaints in the family members, and she has two more siblings, but they don't have any spectacle use. Coming to the general physical examination, she is moderately built and nourished. She is well oriented in time, place, and person. Conscious, cooperative, afebrile. Her vitals were stable. There was no other signs. Coming to the ocular examination, her head posture was normal. Ocular posture was orthotropic. Facial symmetry was maintained, and extraocular movements were full and painless. Coming to the vision, in the right eye, the uncorrected visual acuity was 6/36, and in the left eye, it was 3/60. The best corrected vision was 6 parts in the right eye with a near vision of N6, and the best corrected in the left eye was 6/60 with N18. And on retinoscopy, there was minus 3.5 cylinder at 140 with a scissoring reflex in the right eye, and minus 4 sphere with minus 4.5 cylinder with a scissoring reflex in the left eye. Coming to the examination, the eyelids were normal. Munson sign was positive in the left eye. The adnexa was normal. Rhoplas was negative, and the conjunctiva showed pigmentation in the inferior fornix.
No, that is
Torchlight
Dr. Anu.
Yes, sir.
Go back to the previous slide. This is the retinoscopic value, isn't it?
Yes, sir.
So whatever you have written, what was the best corrected visual acuity? I mean, the refraction, subjective refraction.
So subjective. I didn't add in the presentations.
Okay. So what is scissoring? What is scissor reflex?
Scissoring reflex is when there is a multiple foci, focal points. So there will be instead of the on retinoscopy, instead of the light going moving to or against, it goes cross as the blades of a scissors. So
You may. Can you explain it still better? So usually what happens in myopic and hyperopia, and what happens in scissors reflex?
there will be either with the movement or the against the movement. So instead
Okay.
of that, in case of the keratoconus, so since there are multiple focal points, because of the astigmatism, the reflex will move as like the blades of a scissor, that is crosses each other.
Okay. It doesn't cross, it comes, the reflexes come in between, again they go back.
Go back. It comes in.
Yes. And what are the causes for scissoring reflexes?
Anything that causes irregular astigmatism can cause scissoring reflex, sir.
Any irregular, suppose the patient is normally.
Lenticonus.
One is your case, keratoconus.
Keratoconus, sir.
Yes. Any other causes for scissoring of the reflex in retinoscopy?
Yes, sir.
Any abnormalities of the lens, you can have a scissoring. Yes.
Lenticonus.
Yes. Okay. Okay, go ahead. Next.
Okay, Dr. Anu, you said orthotropic, but as
Yes.
such, like
Yes.
left eye vision, can you go back to
Yes,
vision?
less.
Like whenever one eye vision is very less as compared to other eye, like you should be sure about this visual axis, what you are mentioning. Okay,
Yes,
go back to the next slide. What else would you see in conjunctiva?
We should look for any signs of allergic eye disease, ma'am. Like, so patient is giving a history of excessive eye rubbing also. So we should look
Yes.
for signs of allergy.
Yeah, so papillary reaction if it is there in tarsal
Papillary.
conjunctiva. Yeah, or in
Yes, ma'am.
bulbar
Any
conjunctiva.
tarsal scarring also should be looked for.
Yeah, very good. And what do you think? Which would cause more symptoms? Tarsal conjunctival papillae or limbal papillae?
Tarsal will cause more symptoms because
Yeah,
it
limbal
rubs up.
will cause more symptoms. Patient will be more symptomatic. So because you have given a history of, like you have mentioned specifically that she gives history of eye rubbing and she was self-medicating. So
Yes, ma'am.
you should always look for that also in your examination.
Yes, ma'am. On torchlight examination, Munson sign was positive, and Risuti sign was positive. That is, when we threw light from the temporal part of the cornea, there was a conical reflection of it in the nasal part of the cornea. That is Risuti sign. That was also positive.
And
Coming to the
happens
rest of the
What happens when residue sign is negative? What would happen when you shine the light in the temporal limbus? How would it appear?
It, I didn't get the question, ma'am.
Like when it is negative, but you're shining the light from temporal limbus, how would it appear? Normally, what would happen?
Normally, it should cover, it should be falling on the other part of the, that is the, it should form the, at the edge of the cornea, sir. Crescent like
So like the nasal limbus would be illuminated in an arc-like fashion.
illuminated.
In
Yes,
this,
sir.
you would see, like you mentioned, like a arrow
Cornea.
will be seen.
Yes, sir.
Okay, and what was Munson sign?
Munson sign is the lid deformity on when we ask the patient to look downwards. The because of the steepening of the cornea, the eyeball tend to make a V-shaped deformity in the lower lid of the patient. That is Munson sign.
Okay, please go ahead.
Coming to the cornea examination, in the right eye, there's a steep cornea with thinning at the apex, and there was a subepithelial haze with prominent corneal nerves and a brownish colored subepithelial ring in the inferior part of cornea, suggestive of a partial flesher ring. In the left eye, we could see a conical cornea with thinned out apex and a 4 into 3 millimeter macular grade opacity involving the pupillary axis and infratemporal part of the cornea. And also, a flesher ring was seen in the left eye. The limbus was normal in both the eyes, and the sensations were normal in all the quadrants.
So the term steep is actually like you will say looking at the keratometry. Okay, you do not yet know the K values. I think like this term steep should not be used. You can
Yes,
mention like thinning with ectasia. Okay, like
ectatic cornea.
clinically what you are seeing is you can describe it like that.
Yes,
And in the left eye, you have mentioned the size, the grading of opacity, but you have the depth also. You'll mention in the slit examination, or like the depth of the scar should also be mentioned
it
in
is
this examination.
still the anterior stroma.
Okay. So why do you think the depth of scar is important?
Because if at all we are taking the patient up for a keratoplasty, we have to decide between whether we have to do a lamellar keratoplasty or a full thickness. So if it
Also,
is involving the decimate membrane or there is an acute hydrop that had happened already, then decimate membrane will be involved and there will be extensive scarring. So we cannot go for a lamellar keratoplasty in such cases. So we'll have to
okay.
go for a full thickness procedure in such cases.
No,
Okay.
Dr. Anu, you are in right eye, you mentioned subepithelial haze.
Yes.
Is it really at the subepithelial level or?
Anterior stromal levels.
Okay. Why it is important? Why it is important to know the
Uh,
subepithelial
she is
haze? And
she is
by
also
this
giving
time,
a history. Yes.
yeah, go ahead.
She is giving a history of some eye procedure done, some ocular intervention done to the right eye, which involved putting drops and exposing her to light. So most probably a collagen cross-linking has been done. So we should see whether the so that is why this subepithelial haze is
Whether
important.
this will cause subepithelial level or
It is
uh,
anterior stromal.
yeah, it is the anterior stromal. So
Stromal,
on
yes.
left eye, you have written macular grade opacity involving the pupillary area. And also, madam
Yes.
asked you at what level it is there. So, what level do you expect this subepithelial opacity? I also mentioned you the answer.
Uh, I didn't get the question, sir.
Sir is asking,
See,
sir has already told
Which
actually. Apical
uh,
scarring, TM scarring you told
apicus
about
scarring.
hydrop. So what is
Bowman's, there
actually
can
apical
be
scar? Yeah. That is not
So
very
where when in keratoconus there is breaks in the Bowmans, so that can lead to fibrosis.
Okay.
So that is the reason for the apical scarring.
So yeah, it's so much. It is there is so much importance in that. So if you find haze in the anterior stromal level and haze in the subepithelial level, there is clinically
Yes.
so there is significance is there in your case.
Yes,
Is
sir.
it not? Okay.
Yes.
What does it indicate? There is a subepithelial scar in the left eye. What you can think?
It is an advanced keratoconus.
Yes.
So
Yes, it can be an advanced ectasia.
advanced.
Okay. What
Can
is
you
Shall I
it?
move
elaborate
ahead?
on flesh?
Yeah.
What ma'am?
Pleasure ring, what it is and
So
how it is best
flessuring.
examined.
Flessuring is due to iron deposits from the tear film. It happens in the subepithelial level. That is at the base of the cone. That is at the base of the cone. In the basal layer of the epithelium is where the
Deposition in the
iron.
epithelium. Yeah.
Yes.
In the epithelial layer.
Yes.
How do you
Basal layer
examine?
of epithelium. We use a cobalt blue filter, which makes it more enhanced.
Okay. And
Okay.
what happens to the margins of the ring as the cone progresses or when the disease is more advanced? Uh, is the ring seen more prominently or it's difficult to visualize?
It's difficult to visualize.
So it becomes the margins become more prominent. So it defines the cone more properly as the disease advances. So why does it deposit at the base of the cone?
Because the tear film, like whenever there is an ectasia, the tear film, there will be a tear film abnormality also. So basically, at the ectatic point, the tear.
So what are the other causes for this flesher ring? I mean, iron ring.
Iron ring. So there is a Stocker's line in case of pterygium.
Okay.
Then Ferry's line anterior to a filtering bleb. Then
Okay.
Hudson-Stally line in case of older patients.
Old age. Okay. So why does this iron comes there? Why not other metal?
I'm not sure.
That's what madam is asking, and even I have a question for you.
I'm not sure of the answer.
So what is the common factor in all these things? You said pterygium, bleb, and cone. There is a elevated lesion, isn't it? At
Yes,
the base of the elevated lesion, there will be disturbance in the metabolism of iron. Okay, that get deposited at the.
okay, sir.
I think sir accidentally got disconnected. So there is a stasis of tear film wherever. So there is pooling basically because of abnormal shape. So all these places like wherever there is blood or there is a cone, there'll be pooling of tears. So there'll be leaching of ferritin, and then that will get deposited. Okay. So similar to pleasure ring, what is another? Not similar, different. But what is KF ring?
In copper, there are copper deposits at the level of decimate membrane.
Yeah, so that is at desmet membrane level, and that is a copper deposit. And this is at epithelial level, this is iron deposit. Okay, please go ahead.
So anterior chamber, the depth was Van Herrick's grade 3 and it was optically clear. Iris was of normal color and pattern. Pupillary examination was within normal limits and lens was clear. Intraocular pressure was 14 millimeters of mercury by mercury in the right eye and 17 millimeters of mercury in the left eye. So this is
Ideally,
the
we mentioned your IOP node at whatever time, and using Goldman's
Yes,
applanation tonometer or
at
LC, like
relation
already
to.
mentioned that also. Okay.
Yes. Yes. So this is the slit lamp image and the schematic diagram of the right eye. So here we can see the partial flesher's ring, which is not much visible in the slit lamp image. And there is a thinned out cornea with a subepithelial haze, which is again not very visible in the slit lamp image. This is the diagram of the left eye. Here we can see the macular grade opacity, which is involving the pupillary axis and inferotemporal part of the cornea. And there is thinning and a conical like ectatic cornea that we can see here with the scarring at the level going till anterior stroma.
Okay.
Fundus examination using 90
Dr. Anu,
yes, sir.
first question. Why it is IOP is important in your case? Measurement of IOP.
One thing is, sir, she gives history of using over-the-counter medications, which can be steroid eye drops.
Yes.
So we have to check whether the IOP has increased. Then due to excessive rubbing, there can be increased cytokine production.
Why do you think it is steroid? Why not other? Because she gives a history of itching. So usually,
Itching.
yes, usually they give steroids and all in medical shop. And
Yes.
okay. Then
All
these signs, whatever you have mentioned here in the right eye, left eye,
Yes.
what are all
Yes,
the
sir.
other signs, early signs of the keratoconus and late signs of the keratoconus?
Early signs. Other sign is, sir, on distant direct ophthalmoscopy, we can see an oil droplet reflex.
No, in yes, okay, in slit lamp.
Early sign.
You said there in the left eye there is a subepithelial opacity, and also you said it is maybe a advanced keratoconus.
Yes, sir.
So
There can
what
be
can happen?
prominent corneal nerves. Prominent corneal nerves is one slit lamp sign.
Okay, okay.
Then there can be
how they appear in the slit lamp examination, corneal prominent nerves.
prominent. That is, they appear because of the ectasia and stretching of the cornea. They become more visible.
Okay. What are the other early signs of keratoconus?
Other sign is then the ectasia of cornea with the thinning. That is
Early
one sign,
signs.
sir.
It will be seen in the deeper layers of the cornea.
Then Vogue striae, sir.
Okay. Can you describe
Vogue
the
striae.
Vogue striae, how they look? And
Vogue striae, vertical striae, which is seen in the posterior stroma, level of posterior stroma.
At what level?
That is due to posterior stroma, sir, decimate and posterior stroma.
Okay.
So
Deep
that
to
is
the
because
posterior
of
stroma.
stretching. Yes, sir. Stretching of the posterior part of the cornea.
Okay.
Characteristically, when you apply pressure, what happens? Characteristically,
Apply pressure,
how it
it
is described?
disappears. It disappears on application of pressure.
Okay.
And also, your patient is using steroids for what other condition? Probably steroids. For one was topical. What else she had?
I didn't get the question, ma'am. Once more.
You mentioned like she's using, like Sir asked, why IOP measurement is important
Measurement is important.
and risk assessment also, because we have to rule out any steroid-induced glaucoma also. So steroid, we're assuming she has been self-medicating. What other medication also she's taking that you have to keep in mind? Any systemic association you mentioned? Which you mentioned in history. What else she has?
Bronchial asthma history is there. So inhaled steroids also she's on.
Yeah. That history also you have to take what medication she is taking, and you have to make a note that at every visit, because steroids topical it will be under your control, but you have to keep in mind this about systemic steroids also. Okay.
Not audible, ma'am.
No, now what madam is saying,
Hmm.
doctor. Now madam is audible? No?
Hello.
Now,
Am I audible now?
yes, now
Yeah, no,
it's
I was just
audible.
mentioning that see, you have to make a note, like on her every subsequent visit, you have to always make a note of her intraocular pressure as well as optic nerve
Sure.
head assessment. That should be kept in mind. Steroids you might not be
Yes,
giving topically, but because she is on systemic steroids, so you have to just make a note of that, like at every
yes,
follow-up
ma'am.
visit. So that is also important.
Yes, ma'am.
Dr. Anu, you said there are prominent corneal nerves in right eye. So what are the other
Yes.
causes for prominent corneal nerves?
So leprosy is one,
Okay.
neurofibromatosis
Okay.
is one,
Hmm.
then Fuchs dystrophy, or we can see
Yes,
sometimes.
yes.
Then
Hmm.
PPMD,
Hmm.
then Refsum's disease and men diseases, or men multiple endocrine neoplasia also
Yes.
it's mentioned.
Uh, anything else you, when you said oak stray, any other stray, you know?
HAP striature in congenital glaucoma, which is horizontal striae.
Okay.
And also, so birth trauma can also cause striae, so forceps
Okay.
delivery, or
Okay. How does that will differ with the stray
that
birth
does not
trauma?
go away on application of pressure. So,
Okay. Usually that birth trauma stray will be very coarse. It is actually rupture in the descendant membrane. Then it will
yes,
go
sir.
for scarring. Okay.
Yes, sir.
And okay. And usually there will be these stray due to birth trauma larger. Here you see
Yes,
very,
small.
yes. Okay, go ahead.
Coming to the fundus examination, so after dilation of the patient, we could observe on retroillumination, we could observe oil droplet sign. And on the fundus examination, the optic disc was round, normal in size. Color was pink. Neuroretinal rim was healthy with a cup disc ratio of 0.3. Blood vessels with an arteriovenous ratio of 2:3. The foveal reflex was present, macula was normal, and the background retina was also normal. Coming to the provisional diagnosis, right eye is keratoconus, status post C3R. Left eye is advanced keratoconus with apical scarring.
So I think like it should be both allergic conjunctivitis, like if there were papillary reaction, we are just assuming
Yes.
from history, with keratoconus and bronchial asthma should also come in your diagnosis. Uh, Anything else, sir,
Now, why
in
do
the
you think,
diagnosis?
now what are the, according to history and finding, do you think it is post C3R, right eye?
Because the patient gives, first of all, in the history, patient gives a history of undergoing some ocular intervention where some drops were put, and she was, after that, she was exposed to light. So that is one
Okay.
history. And there's a
And
anterior
also,
stromal
as
haze.
madam said, you should have elaborated the history there. Okay.
Yes, yes, sir.
Post-operatively, what happened? Okay.
Yes,
That would give a more clue. Okay.
yes, sir.
Then what else?
Then there was an anterior stromal haze, which might be a post C3R demarcation line.
Okay. Why they are not done C3R for the left eye?
Because probably
They are done only for the
that
right eye.
time it was already scarred, sir. So probably that.
That is the only reason or anything else?
The advanced thinning of the cornea, sir. The corneal thickness
Okay.
will be very less. So
So how do you
that is
know? How do you know that keratoconus is advanced or early stage by doing any?
yes, sir. over a period of 1 year, if at all the
First of all, what investigation will do?
we have
Investigation.
to, refraction is important, sir. Investigation.
Okay.
We have to go for a oculizer, sir, in case of tomography has to be performed. So
Oculizer is a test or a name of the instrument?
name, sir.
Okay.
Tomography.
Okay. Tomography you would like to do. Very good.
Tomography is required, and ASOCT to determine the level of scarring is additional investigation required.
So, what is the difference between a tomography and a topography?
In tomography, we get anterior posterior curvatures as well as the corneal thickness.
Okay.
In topography, it is the placido-based topography. It gives only the anterior curvature.
Okay. So tomography is a
better in modality.
Did you do for this patient?
Yes, sir.
It was
I'll
done?
just show the, yes, sir, images I'll just show. So adding to this, keratometry values of the right eye was 45.5 and 50.75. On the left eye, we got distorted mice. The pachymetry was done. For the right eye, it was 480 microns, and the left eye, it was 270 microns. This was the tomography report of the right eye with K1 46.3 and K2 51.5 with mean K is 48.8. Thinnest Pachy is at 468 microns and Kmax is 54.1 diopter. This is for the
pachymetry was available. Previous pentacam was available. Like before she had undergone CCR. Did she have any record?
No,
this was
she did not have. She did not bring any records to the hospital. She came through a community camp, so she did not have any reports.
Okay.
So this was for the left eye, but here the reliability is less because it shows a red here. But K1, K2 59.8, 60.7 with a K mean of 60.3. Thinnest Pachy is 144 and the Kmax is 73 diopters.
Go back to the right eye one, please. The pentacam.
Okay.
So, if the patient undergoes cross-linking, what do we expect on in the curvature map?
There will be no progression of the keratoconus, no?
No, the K values. What would you expect?
There will be.
Like it will be steeper or it will be flatter?
It will be flatter.
But in this, what you're showing, it's quite steep. But we do not have a previous map to compare. But it doesn't look like, I don't know, I feel or might not have been done. I'm not sure. Plus, corneal thickness is also quite good.
481.
In spite of P3R. So I'm not quite sure. So, like, if you have to describe this map in case it comes as spotted in exam, how will you describe this map?
So first we look
said about quality specification that is okay for this one.
Okay for this one. Then the Q value that is it should be the normal prolate cornea. It should be from 0 to -1. If it's more than -1, it is hyperprolate. That means that is a sign of ectatic disease of the cornea. And if it is less than that, that means it is oblate, meaning refractive. Probably a refractive procedure has been done for the eye.
Which type?
Then myopic ablation might have been.
Go ahead. How will you read systematically this pentacam map?
Then we go on to the K1, K2. So K1 is the flatter axis and K2 is the steeper axis. So then the K mean of both that has to be taken into consideration. And it also gives the astigmatism also. That also we should mention.
The central zone. Basically,
Central zone.
yeah, the machine actually calculates the flattest meridian and it takes the meridian perpendicular to that, which is the steeper one. It is not the
Deeper.
steepest one, like you mentioned, that K max is not same as K2.
Yes, ma'am.
Okay.
Okay. Then again, we have to check the pack key values. This is the pack key at the vertex will be shown. The thinnest pack key is also shown. So the difference between both these should not exceed 10 microns. Which is again, if it exceeds 10 micron, it is indicative of an ectasia. Then the K max is 54 here. So that is also steep. Then coming on to the maps, we have to read the maps one by one. So first is the axial or the sagittal map, which shows the curvature. So here, usually, here we see a irregular astigmatism in this map. So an asymmetric bow tie appearance is what we classically give for a keratoconus. Here we can see a skewing also. Then this is the anterior floor.
Is there a symmetrical bow tie there?
Sir, it is more like a skewed appearance, sir.
Okay. It is actually it is very steep, and if you look at the center area, there is a symmetrical bow tie and lot of skewing is there.
Yes, sir.
Okay. Okay.
So this is the thickness map. So here, this is the thickness at the vertex 481, and we also see these points. So the normally, if it's less than 500 microns, it is said to be a thinner cornea. The normal is from 500 to 550 microns. So then this is the anterior float. So here,
And there is also like horizontal displacement of your sinus looking. Like
what?
Usually the pachymat is concentric. In this one, you'll see little horizontal displacement of your
little
sinus.
shift is there. Yes.
Yeah. Elevation map.
So the elevation maps are, this is for the anterior surface, this is for the posterior surface. So it is compared to the normal reference range for that for a population. So this any point in the center which is exceeding more than 12 microns is suspicious of an ectatic disease, and more than 15 is like confirmatory for a keratoconus. And in case of posterior map, the ectasia will be more compared to the anterior map. So here, any point giving more than 15 is suspicious, and more than 20 is confirmatory for ectatic disease.
And also the difference between the two at same point should not be more than 5 microns.
Should not be more than
that is also like a lot of differences there in this one, if you see. So plus 13, and here it is plus 30 at the same point.
Yes, ma'am.
There's a lot of difference between the two.
Suppose you have taken this in one patient, okay, this pentacami you have made, and you have a little bit doubt whether it is a keratoconus or is it a normal. So what further test would like to do? Or investigation? This is a 4-chord map, isn't it?
Yes, ma'am. Yes, sir.
Okay. Then you were taken in a patient where you are suspecting keratoconus, but map doesn't looks like keratoconus. You have a doubt.
Belin-Ambrosio was
okay, good.
That map has to be taken.
Okay. Shortly, in brief, can you tell what is Belin-Ambrosio map?
So in Belin-Ambrosio, we take a modified best fit sphere for the patient, and based on that, the elevations are calculated. So the thinnest area, there will be the anterior graphs and posterior graphs. So, and there's a difference between the both that is also depicted. So that and it
Okay.
is also color coded. So anything in yellow is suspicious. Anything in red is like confirmatory.
Okay. Actually, you should not go
And there
by
is a
the. You should also see the values there.
Color. Yeah, you should
Okay,
not
not
know where the
uh,
color.
okay. You should also know the values. Okay.
And there is also a
So,
thickness map also where it
hmm,
shows the progressive thickness starting from the central cornea to the periphery. So usually it should the patient's value will be the graph will be drawn along with 4 reference values. So it should be between the 4 reference graphs. And if at all it is deviating before reaching 600 microns, then that is also indicative of a ectasis.
Millimeter. 600 microns. Before 6 millimeter.
Six
If there is
millimeters, sorry.
sudden dip.
Yes, 6
uh,
millimeters.
Oh,
so what is a form first keratoconus?
Home firstly, there will be no symptoms or signs for the patient, and best corrected vision will be okay. But on Belin-Ambrosio, there will be changes which shows
And
suspicion.
cord map?
Cord map also, there will be no changes, sir.
Good. So, good. And
no,
what you would like to
for
do
either
for this patient?
elevation, there will be
Yeah,
changes. And we will see an elevation map. Only then it will be displayed in your Belin-Ambrosio. So there will be some changes, some signs. Clinically, you will not be able to see any signs of keratoconus on slit lamp examination.
Yes, ma'am.
So what is the diagnosis like staging? Do you know any classification system or staging of keratoconus?
Amsler, Amsler chromatography classification is one. We have 4 stages for this, and also an ABCD classification is also there.
Okay, good. So, like now you have diagnosed keratoconus in this patient. What would you
Yes,
like to
ma'am.
establish first? First thing, what would you like to establish about keratoconus in this patient?
The visual potential of the patient we have to check first.
Okay, so one is visual potential, and what is the second most important thing?
Contact lens trial.
hmm,
Uh, that is vision. Okay, what else?
Yeah.
Like two things you have to look for in a patient with keratoconus. You have
Mhm.
to establish one is visual potential, you said. What is the other thing which you have to establish? For which
Arresting the progression
assume
of
yeah. So first you have to ascertain whether keratoconus is stable or it's progressive. So if we
progressing.
had a previous map of this patient, we could have compared. But in this
Yes, ma'am.
case, we do not know. Okay. So
We
what
don't
would
know.
be your plan of management for right eye in this patient?
So in the right eye, we can ask for a contact lens trial for the right eye, probably. Uh,
No,
the
that is
so
for
direct
let me.
refraction.
Okay. So first thing, okay, so what we'll discuss it in two parts. One is we have to ascertain whether it's progressive keratoconus or it's a stable keratoconus.
Stable
First, we'll only
keratoconus.
concentrate on that. Okay. If it
Yes.
is progressive, we have to go ahead with cross-linking. Okay. If it is
Yes,
not, if it
ma'am.
is stable, then we will see what are the options for visual rehabilitation. Okay.
Yes, ma'am.
In, do you have an ASOCT also for this patient, like the demarcation line, what you were saying? Do you have?
Actually, it is there, but I'm not included in the presentation, ma'am.
You could see the
I,
demarcation
we,
line.
we could see a demarcation line in the anterior stroma.
Okay. So probably in this patient, because corneal thickness is still close to 470, probably I will repeat, I'll take this as baseline if she doesn't have previous scans. In case she has previous scans, I would ask her to bring those scans and compare. Otherwise, I would repeat the topography in probably, I'll control her allergy and probably repeat her scan first, maybe in 3 months, or otherwise, because she's 26-year-old, probably in 6 months. And if there is progression, she would need cross-linking for right eye. It can be repeated also.
Yes, ma'am.
So that, and because you already told that right eye vision was improving to 6/6, so she has good
Six,
vision.
six. Good
And if she is
vision.
happy with glasses for right eye, there is no need for any other, like for quality of vision, we can do a contact lens trial. But otherwise, if she is improving with glasses, so right eye vision is sorted. Only we have to ascertain whether the disease is a progressive disease or it's become stable. Okay.
So,
And what about left eye? What do you think for left eye? What will you do?
so the left eye shows a scarring, which is up to the level of anterior stroma. So actually for this patient, we tried a contact lens trial, but the vision was not improving. Dilated refraction also vision was not improving. So we would have
Say
to go
values
for,
more than 55, it will not be very steep. They should not be happy with contact
yes,
lens.
yes.
So what will you
So
do?
we will have to go for a keratoplasty, probably a anterior lamellar keratoplasty in form of DALK.
Why would like to do DALK for this patient? Why not penetrating keratoplasty?
Because the lamellar keratoplasty has comparative lesser complications compared to full thickness keratoplasty. First is it is a closed globe surgery, the DALK. We are not opening up the globe. Um, then the visual recovery is also faster in case of lamellar keratoplasty compared to a full thickness keratoplasty. Uh,
And
so
what is the
that
most
is.
important thing? Most important, advantage
And
of
the
lamellar.
sir here endothelium is not affected, so we don't have to change the. So there is rejection level is
Yes.
also lesser. So steroid use
Rejection is
also will be lesser for a
yes.
lamellar.
The most important thing is the rejection is very less.
Lesser.
Okay. So, can you tell me, classify the lamellar keratoplasty?
Lamellar, anterior lamellar keratoplasty and posterior. Posterior
Okay.
in form of so anterior includes DALK basically. Then we have DMEC and DSEC in posterior, as well as PDEC also in posterior.
Okay.
Anterior
Then
is only dull. Anything
Anterior in it.
superficial to do?
SALK, SALK is also there.
So, what is the difference between DSEC and DMEC?
So in DMEC, only the descemet membrane and endothelium is transplanted. In DSEC, a small amount of stromal tissue is also there. So the thickness of the graft is also different, as well as the learning curve for the procedure in case of DMEC is more. But the rate of rejection is lesser for DMEC because trauma is not taken in the tissue.
Suppose you have done a DALK for the left eye, okay, and you will
Yes.
have some, DALK is successful, and so patient won't improve vision. The vision is not improving even after doing DALK. So, what are the options to improve the vision?
Again, sir, after this visual rehabilitation, either with a contact lens or
Okay.
a
What
glass
contact
should
lens
be
would like to? What contact lens would like to?
scleral contact lens or
Okay.
so that whatever in keratoconus there is a irregular astigmatism basically. So because of that, even with the glasses, sometimes the patient's visual clarity will not be that good. So when we are using a contact lens, because there is a tear film in between the space in the between the contact lens and the ocular surface, that all
That
the
is for okay.
irregularities goes in. So
For
contact lens
scleral contact lens.
in
Is it?
scleral contact lens.
So what other contact lens options we have?
Row scale lenses are also available, sir, where
Okay.
the posterior part of the lens has a protrusion so as to accommodate the ectatic portion of the cornea and thus
Okay.
minimize the irregularities on the surface.
What if the patient doesn't want to wear glasses or contact lenses and has stable keratoconus? It's not progressing. You have
Right
observed
eye.
for 1 year. What for, like, and she doesn't want to wear glasses. She doesn't want to wear contact lens. Anything else you can do? Anything else you can offer her?
She wants a permanent solution.
Not sure now.
Anything you can implant?
ICRS, intracorneal ring segments.
No.
So
No.
Inside
No,
the
what,
eye, any
madam?
contact lens inside the eye? Anything?
After, no, this is
Take it
after
out.
C3R. Yeah.
yes.
One option, but if it is stable, you have a certain that it has not progressed for 1 year, it is stable, and she doesn't want to wear glasses or contact lenses, then that is one option. And the vision should be improving with glasses. It should not be like the vision is not improving with glasses, it's only improving with contact lens. Then that is not an indication. It should be improving with glasses. And you mentioned about ICRS. What does it stand for?
Intracorneal
That is
ring
another.
segments.
Okay.
That is another modality. So
What is
basically,
the
what it
contraindication? What is the contraindication for ICRS? Where you will not give this as an
excessive,
option.
thinned out cornea, we cannot use ICRS.
And what else is there in left side?
Scarred cornea.
Yeah.
Good. That may be the reason you did a contact lens trial. The vision was not improving. Yeah. You are sitting in a classroom or you are in a room? Where?
No, sir. I'm in room, sir.
Okay. Just I was thinking any other students are there.
Any other questions? Anyone else has joined?
I think there are no other students there.
Yeah, no questions in chat also. Yeah.
Yeah, in chat box, any questions?
In this,
All questions will go to
Any
Anu.
questions in YouTube?
Yeah.
No, ma'am. Okay.
Okay, very good,
I
Dr.
think
Anu. You studied thoroughly. Good. I presented well.
One more thing we can cover, the DDs of keratoconus also we can cover. Probably.
Yeah. Yeah.
Okay.
So
one
whenever
is
someone
the
asks you about
So
so whenever you're asked about ectasia, what all should come in your mind?
others PMD, pellucid marginal degeneration. Then Terrien's marginal degeneration is one. Then keratoglobus. These are the other ectatic conditions and
And one more, which is not seen in virgin cornea. One more, post some procedure, ectasia.
post-LASIK ectasia.
I think we will conclude. Okay.
Okay.
Thank you, Dr. Akanksha.
Okay, thank you, Dr. Anu. Thank you, sir.
Thank you.
Thank you so much, ma'am and sir.
Goodbye. Good night.
Good night.